Thank you, Dr. Reem, for the introduction. Thank you, everyone, for being here, and thank you to Mr. Scientific and Education Committee for inviting me to be speaker today. I'll talk about review of breast cancer management, and as you all know, this topic can take at least 2 hours. I've got 20 minutes, so I'll try to stick to it by highlighting the important points and also highlighting the important ongoing trials. These are my outlines. So regarding the breast cancer staging, basically it has moved from anatomical staging, TNM staging, to anatomical and prognostic. And this incorporating the TNM along with the ER, PR, and HER2, as well as grading to try to find those prognostic factors. Even more, we have the multi-gene assays of Oncotype DX incorporated in the staging in the 8th edition. Nevertheless, we still have to use the TNM classification because it was used in all the trials, mostly until now, with early stage breast cancer being stage 1 and 2, except T3 and 0, which is mostly categorized with locally advanced disease along with the stage 3. So for early stage breast cancer, from radiation oncology perspective, we have several options in the adjuvant setting, including adjuvant breast or chest wall radiation with or without regional nodal irradiation, accelerated partial breast irradiation, and emission of RT. These are the landmark trials that have set the bar for breast-conserving therapy to be the standard of care and proven to be equal to mastectomy in terms of disease-free survival, distant metastasis, and overall survival. Of course, there are some contraindications to breast-conserving therapy, like patient preference, having high risk of local recurrence post-breast-conserving therapy, like having a multicentric tumor or persistently positive margins. Some other contraindication to radiation may include pregnancy, prior radiation to the chest or breast area, or poor cosmetic outcome expected with breast-conserving therapy. As a local treatment, the primary focus of radiation effect has been always on the prevention of local regional recurrence, but with better understanding of its effect, it became known that it has also a systemic effect, as my colleagues in their previous presentations have mentioned. So the 2011 meta-analysis from EBCTCG basically restricted to patients who undergone breast-conserving surgery showed that radiotherapy reduced the risk of first recurrence, whether distant or local regional, but about 50%, which translated into reduced risk of breast cancer death. Now, the fractionation for whole breast radiation, it has been the standard of care that we use standard fractionation in all the previous trials that we mentioned that has set the bar. But then moderate hypofractionation was compared to normal fractionation and proven non-inferiority. And the main trials are the UK START and the Canadian Oncology trials, which compared 3 weeks versus 5 weeks regimen and proven that 3 weeks are non-inferior. We cannot move forward without talking about the Fast Forward trial, which tested the ultra hypofractionation in early stage breast cancer, so 3 weeks versus 1 week, and sequential boost of normal fractionation was also allowed. There was some node positive patients on this trial, but nodal RT was not allowed, and there is a formal sub-study from Fast Forward that is testing 40 in 15 versus 25 in 5, 26 in 5 for regional nodal irradiation. The conclusion of the Fast Forward, the main study, is that 26 in 5 over 1 week was non-inferior to the 3 weeks regimen in terms of local control and safe in terms of normal tissue effect up to 5 years. Since we're talking about fractionation, this is also one of the unresolved questions until now in our field regarding the hypofractionation in the reconstruction setting. And MAC23 is an ongoing trial for patients who underwent mastectomy and plan to have a local regional treatment, and they are randomized to normal versus hypofractionation, the 3-week regimen, with a primary objective to evaluate the reconstruction complication at 24 months. Moving on to the tumor bed boost, these are the main trials that have established the evidence behind it. the longest follow-up and the most number of patients are in the EORTC trial, which basically took the early stage breast cancer patients, randomized them to 50 and 25 with or without boost, with a follow-up of about 11 years. Basically, everyone benefited. But the magnitude of benefit varied. And then when weighed with the risk, like severe fibrosis, this has led to some variability in the booster practice among centers, although young age and close or positive margins are among the top indications. Others may also add high-grade LVI and age up to 70 among the indications for the boost. Now, after so much of research trying to identify the risk factors for local recurrence, now we have better understanding of clinical pathological risk factors like young age, LVI, sensitive intraductal component, TN factors, and lobular histology, margins, and appropriate systemic therapy use. Combining those clinical pathological with molecular subtyping gave us better understanding of the low versus high risk breast cancer for local recurrence. And now we know that luminal A has the lowest rate. And the implication for that is that we are trying to de-escalate treatment in selected group of patients by using partial breast irradiation or omitting RT altogether. So APBI is the delivery of hyperfractionated radiation to high-risk breast only, so lumpectomy cavity with a margin, with a goal of having local control that's equivalent or non-inferior to whole breast irradiation. There are various techniques to deliver it, such as brachytherapy, intraoperative, and external beam, and the evidence behind it is so much, and much more than this. For APBI, it has a comparable local control to whole breast radiation in selected low-risk early-stage breast cancer. And as of now, there is no optimal technique or fractionation. But according to the ASTRO 2016 suitability criteria, it can be considered in BRCA-negative patients who age at least 50 years or more, invasive ductal carcinoma, early stage T1N0 with adequately negative margins, no LVI, ER positive, or low-risk BCIs. Now, I'm not going to talk a lot about omission of radiotherapy because also the next presentation is about caution about the escalation of management. But just to say that there has been a lot of trials that are that have tried to omit radiation in selected group of patients. There has been always difference in terms of local control with a better outcome when radiation was added, but no impact on survival. The Lumina trial is the most recent one published just this year by the Canadian group. And I think the next presentation will elucidate more about it. And now we are using multi-gene assay to direct radiotherapy in those early stage luminal A breast cancer. The Lumina trial is the only one that has been completed and published so far. IDEA, Precision, Expert, and DEBRA are undergoing and using variable multi-gene assay way like Ki67, Oncotype DX, or PAN50. Moving on to the next half of the presentation, it is about regional nodal irradiation, which when we say it, we're talking about irradiating the undissected axilla, supraclav, and IMN. And historically, of course, post-mastectomy radiation was offered because patients presented at later stages, and there was no or inadequate chemotherapy. It improved local control, but not survival, and increased toxicity, especially cardiac and lung. Also, historically, there was significant heterogeneity in the surgical and radiation techniques and lack of systemic therapy. Of course, the Danish and the BC trials are the one that mainly set the bar for post-mastectomy radiation to be standard of care at the time, because they showed in node-positive disease there is overall survival advantage as well as local regional control. But major criticism basically is that they used either no or inadequate chemotherapy, and there was inadequate axillary surgical management. And subgroup analysis from the BC trial showed that the benefit of post-mastectomy radiation was not only for those with 4 or more lymph nodes, but also extended to those with 1 to 3 lymph nodes. And so EBCTCG meta-analysis has put it together that after mastectomy and axillary dissection, radiation reduced the local regional recurrence, overall recurrence, and breast cancer mortality in women with 4 or more lymph nodes, as well as 1 to 3 positive lymph nodes. Then now we have the more modern trials supporting RNI in early stage. The major ones are the ERTC 22922 and NA20. So ERTC basically took pathologically node positive patients or node negative patients who are central or medial tumors. About 1/4 of patients had mastectomy, and there was a little bit over 4,000 patients on this trial. At the 10-year mark in New England Journal of Medicine in 2015, they published their 10-year result, which showed improvement in disease-free survival, metastasis-free survival, and breast cancer mortality with the addition of IMN irradiation, but no survival benefit. There was a little bit of increased toxicity in terms of pulmonary fibrosis at 10 years, but no differences in cardiac or other toxicities. But then in 2020, they published their 15-year result, and there was no more disease-free survival advantage or metastasis-free survival or overall survival. So there were just breast cancer mortality and any breast recurrence advantage with the IMN irradiation. The NA20, again, early stage node positive or high risk node negative patients all had lumpectomy on this trial, and all node positive has axillary dissection. And of note, the percentage of node negative patients on this trial was less than 10%. Their 10-year result also was similar to the 10-year result of the ERTC and showed improvement in disease-free survival and distant metastasis disease-free survival, but no improvement in this overall survival or breast cancer mortality. There was a bit of increase in the pneumonitis as well as lymphedema, but no differences in terms of cardiac toxicity or second malignancy. Adding more to the IMN question, whether it is beneficial or not, there is a Korean trial that compared IMN versus no to not positive patients, and it showed no improvement in disease-free survival, but improved the outcome for central and medial tumors. And then there is the Danish group, which reported the 15-year follow-up of their study, where they gave radiotherapy to the right-sided patients who are not positive, but not to the left-sided patients. And they had about 1,500 patients on each side. So they showed that at 15-year, there is overall survival benefit and improvement in the risk of distant recurrence and breast cancer mortality favoring radiation to the IMN. It's a bit confusing, right? So as the data regarding the benefits of IMN radiation are conflicting, clinical judgment is really needed when determining the inclusion of IMN during RNI. And at the moment, NCCN panel no longer specifies the fields that should be included for RNI and refers to it as comprehensive RNI. So for me, the indications for post-mastectomy radiation, it's clearly indicated for all node-positive patients in T4, and they are to be considered in node-negative patients with high-risk features. For post-lumpectomy, local regional radiation is also clearly indicated for all node-positive patients and may be considered in some high-risk node-negative patients, especially if they are central or medial tumors. There are more efforts also in de-escalating the treatment in terms of regional nodal irradiation. And this one, the Taylor RT from the Canadian group by Tim Whelan and his colleagues, they are trying, it is an ongoing trial. They are trying to get the biomarker low risk node positive patients, so ER positive, biomarker low risk by having oncotype DX of less than 18 and limited nodal disease, and who are going to get endocrine therapy for 5 years. So randomize them to regional nodal irradiation versus no regional nodal irradiation. Again, remember, this is a node positive patient, but limited nodal. The last part is about regional nodal irradiation in the neoadjuvant setting. It is still an ongoing dilemma, with the current evidence from coming from mostly retrospective data, and the best quality data available now is from the combined analysis from NSABP B18 and 27. And this combined analysis by Mamouna et al. And the JCO is, I think, it's very great. The aim was to identify the predictors of local regional recurrence as the first event. In these trials, there was no regional nodal irradiation. So those who got mastectomy got no radiotherapy. Those who got lumpectomy got only whole breast irradiation. And the predictors were mainly age, clinical tumor characteristic before neoadjuvant chemo, and the response, pathological response post-neoadjuvant chemo in the breast and in the knees. And these nomograms in the paper, I think, are really helpful tools that sometimes we use in the clinic to aid in the clinical decision-making process. Also, by Mamounas and his colleagues, they reported by tumor subtypes, the lowest risk is hormone receptor positive, HER2 negative, and the highest risk for local regional recurrence, of course, the triple negative and the HER2 positive disease. So in the neoadjuvant setting, post-breast conserving surgery or mastectomy, local regional radiation is indicated for clinical stage 3 and YP node positive, of course. I would also give to YPT3 as it indicates poor response to the neoadjuvant therapy and clinical T3 with residual breast disease. Last word is about sentinel lymph node biopsy role post-neoadjuvant chemotherapy. So if the patient is basically clinically node negative pre and post chemo, we can do sentinel. If it's positive, dissection. If it's negative, no further axillary management. If the patient is having clinical N2 or N3, despite the pathological response, it's axillary dissection and regional nodal irradiation as a standard of care. And the same for those who are clinically N1 pre and post chemo. Now, the most controversial issue is about those who are clinical N1 pre-chemo and clinical N0 post-chemo. And these mentioned the trial have tried to see how we can get the false negative rate to the lowest for the sentinel lymph node. So we have to get some strict criteria, like having at least 3 sentinel lymph nodes removed. They have to be negative by IHC. Both sentinel and clip nodes are removed and negative, and using dual tracer. But unfortunately, this is not the real life. Not everybody sticks to this in their practice. And so for now, most of those patients get regional nodal irradiation. Last 2 slides, this is about the ongoing B51 and the alliance protocols. So these are eagerly awaited trials to be completed and having results, because this is testing clinical N1 disease who convert to pathological N0 post-neoadjuvant chemo. So do they really need radiotherapy, regional radiotherapy or not? This is the randomization with the primary outcome, invasive breast cancer recurrence-free survival. And the second one is the alliance. It is for clinically node N1 who remain positive lymph nodes post-neoadjuvant chemo. Do they need dissection or is radiation enough? It is like sort of similar to the Amaros trial, but in the neoadjuvant setting with the same primary outcome. With that, I conclude and would like to thank you for your attention.